Well, once again, thank you for joining us in another in our series of interviews with the experts here at Mayo Clinic. I'm your host today, Malcolm Bell, and I'm joined today by my colleague, Dr. John Giudicessi. John is a consultant in a division of heart rhythm services. He is an assistant professor of medicine. He's also an assistant professor of pharmacology. And today we'll be talking about genetically mediated cardiovascular diseases. So, John, thanks so much for joining us today.
Well, thank you for having me. So it's a pleasure.
Great. Well, as I said, we're going to be talking about genetic mediated cardiovascular disease, but in particular, we're really going to focus on gene therapy. And I wonder if maybe, and this is really an exciting area, and I think a lot of us are not really quite clear what that really is. So maybe we'll just start off by asking you, what is gene therapy? And maybe as you answer that, maybe even just tell us, how is that different to cell therapy?
And
So two areas that perhaps poorly understood by the people who are not directly involved in these areas.
Yeah, no, it's a really fantastic question. And I think what you need to do there is to differentiate what is being altered or what's being introduced to human cells. And so gene therapy is really the idea that you're going to introduce some sort of therapeutic nucleic acid. So that's either DNA or RNA into a cell with the goal of either treating or curing or taking care of a disease. Where cell therapy a little bit different. That's just the introduction of therapeutic cells, so cardiomyocytes, right, for regenerative medicine. And so the idea here is really we either want to repair a person's DNA, give them back a piece of DNA that they're missing, okay, and then hopefully that will then either freeze their disease or hopefully then actually cause it to regress. And so that's the goal of gene therapy. And I really view that as the ultimate precision medicine, right? Because it is actually altering the genetic defects that then drive some of these genetic diseases or genetic heart diseases that I take care of day in, day out.
Okay. And so we've got a cardiovascular audience here. So what are the diseases that you're focused on and your colleagues?
So my primary focus, so I'm a genetic cardiologist, so that's what I do, but I really focus on genetic cardiomyopathy, so things like hypertrophic cardiomyopathy, arrhythmogenic cardiomyopathy, then the channelopathies, which are these sudden cardiac death predisposing diseases that involve how the ion channels that conduct our heart's electrical activity function. But most of the movement in the gene therapy space has really been in the cardiomyopathy realm because those diseases are often caused by genetic basis where you're missing a copy of a gene. So it's easy to replace something. It's a little bit more difficult to tone something down if it's gained a new function. And so most of the gene therapies that we're seeing in our clinical trial really address these loss of function or what we call haploinsufficiency genetic cardiomyopathies.
Okay. Well, we'll come back to that in a moment. So you started off by saying that this is introducing DNA or an RNA into an individual, into cells. How do you get that DNA and RNA in the first place, before it's actually introduced into a patient?
Yeah, so it's a fantastic question. So a lot of science has gone into the delivery of a new copy of a gene, right? And we've had a lot of failures where approaches have not worked. But the current technology that exists is we actually stole from nature. And that's that there's these naturally circulating class of viruses called adeno-associated viruses that some serotypes or types of the virus they actually have a natural, we call tropism, or ability to go use the heart wall muscle to reproduce themselves. So we said, well, why not reinvent the wheel, right? Let's use what nature's already given us. So we stripped out the DNA from those viruses and then have put in a new copy of these genes. And then essentially then that virus is a delivery mechanism or a delivery vehicle. So it sounds scary like a zombie movie might start, but in reality, we're using nature to kind of deliver a new copy of a gene and using something that nature has given us rather than reinventing something that could potentially be more dangerous.
So again, I was going to roll back here a little bit, but you talked about adenovirus, and you're talking about sort of an affinity for heart muscle. So are these the same sort of so could actually potentially cause myocarditis? I'm not thinking about a risk here, but is that what we're talking about?
A little bit different class of diseases. So adeno-associated virus, unlike adenoviruses, are non-disease causing. So in nature, they're not sitting there. They don't cause myocarditis. They don't cause the common cold. They don't cause anything that you need to worry about. They're really highly evolved viruses that they're the ultimate vehicle. They just want to get into your body use your cell's machinery to reproduce themselves, and then get on to the person next door. And that's what makes them such a great delivery tool.
Well, they sound like little friendly parasites to me, but so then in terms of, their DNA and RNA, so now these are going to be the vector to get into the heart. So can you just walk us through, just in simple terms, of if you're that virus being introduced into the to the patient, what's actually happening?
Yeah, so it's a fantastic question. So what happens is that virus, it's going to bind to cell surface receptors on a cardiomyocyte. So it really only recognizes those cell surface receptors, and that's why it likes to go to the heart. And then once it gets into the heart wall muscle, it's going to unwrap itself, and then it's going to release the DNA or that part of the virus into the nucleus where your genetic material is. And this is when I walk through patients when we're talking about enrolling them in a gene therapy trial. This is where a lot of young men stop in particular, are like, no way, this is exactly how zombie movies start. And I have to walk back and say, listen, no, this is not what's going to happen. So this does not integrate into your genome, right? So the gene therapies that we have in trial right now, what they do is they create a circular piece of DNA called an episome that can stay there for 5, 10, 15, 20, maybe even an individual's lifespan, and then produce a new copy, via kind of the whole transcription and translation we learned about in high school biology. That's how it then expresses a new copy of the gene. So these are important that it doesn't integrate, because that's how you can cause cancer, you can cause other side effects that you don't want, and that this is a circular piece of DNA that sits outside of the patient's normal genetic material.
How do you introduce this to the patient? Is this a simple injection or an infusion? How's it done?
All the current trials that are running now, all use a one-shot therapy. So it's an IV infusion. So we admit these patients to a clinical research unit, and then over about an hour or an hour and a half, we infuse that virus at a very high level to then transduce those heart cells. And with any luck, if they're successful, deliver that new copy via the mechanisms we just talked about.
Okay. And so when it targets the heart, is it predictable whether it's going to just affect a small region of the heart or the entire heart, or is it just purely random?
Yeah, the goal is as many cells as possible. And that's where the trials come in, right? So the trials, what we're trying to figure out, and we do monitor, and how some of the metrics are looked at in these trials are using endomyocardial biopsies to actually look at the heart tissue to figure out how many heart cells did we transduce with a given dose of this gene therapy. The goal is as many as possible. And you really probably need close to 80% to be fully effective. And so that's where kind of time will tell if these work. If we can get enough delivered via these AAV or adeno-associated viral vectors, can we get enough of the new gene delivered that actually makes a difference in these disease processes?
So it sounds as though you have phase 1 trials underway, working and presumably then working out the appropriate dosing and response. Is that
correct? And the safety. So currently most are in phase 1 for Danon disease, which is a rare kind of hypertrophic cardiomyopathy phenocopy that has a phase 2 or a pivotal trial that's being run not at Mayo Clinic, but at other sites in the United States. But right now, the goal is really safety and then early efficacy in these trials.
Now, one of the inherited cardiomyopathies, of course, is hypertrophic cardiomyopathy. And so you're hoping then that you would be replacing or not necessarily, or repairing, the various muscles there or muscle cells. But you could have then a mixture of healthy myocytes alongside unhealthy myocytes competing against each other. Is that too simplified, or again, that just gets back to the dosing perhaps?
It gets back to the dosing, because in theory that could happen. And that's why we really worry about it for more of the channelopathies or the electrical diseases, is that you don't want heterogeneity where you have one cell that's been fixed next to one that has not. In cardiomyopathies, you need a critical mass, right? So again, the goal is, and for hypertrophic cardiomyopathy, it's a gene called myosin binding protein C3, which is one of the primary causes. Those patients are just missing a copy. So the hope is that you get enough critical mass where you restore that defect, that you can actually reverse the process, or you can at least freeze the process where it's at. And that hopefully gives the ultimate precision therapy, because it's not relying on a primary pathway or a secondary pathway modification. This is truly going at the source that's driving that patient's disease.
And so really, really fascinating. So you said one shot, so that comes in you having a single infusion. Is that the end of it? Would you come back for more at another time? Is that, I mean, how do you see that playing out in the future? So, and again, you talked about that, do you have enough of it actually in the heart? And if you have a way to determine, you talked about biopsies, but I'm thinking about it in the future, would this be something you sort of have a sort of maybe a top up, from time to time?
Yeah, it's the $1 million question, right? And so most of the data for these adeno-associated, these gene therapies are more viral based, comes from the neurology world, from spinal muscular atrophy. And we know that in neurons, which like heart cells are non-dividing, that gene therapy can persist for a decade or more. And so the hope is that we can get 10, 15, 20 years out of this. Now the question comes is what if it begins to run out, right? And that is the big thing because once you expose the immune system to these vectors, you really only get one shot in 2025. So there's going to be an entire field then to develop the top-off therapy, right? So if the gas tank is starting to run low, A, monitoring that, but B, then how do you top this off? And that's an entire field into itself, is to figure out how can you evade the immune system and deliver a second round if you need that. For now, I'll just take the therapy, right? If I can have the 10 or 15 or 20 years, I'll take that because right now we do not have any disease modifying therapies for a lot of these genetic cardiomyopathies. So that in and of itself would be a huge step forward.
And in these phase 1 studies, any particular adverse effects that you're seeing? I mean, obviously, you're monitoring very, very carefully, and these patients have already significant disease, that can be life-threatening. But so what are you seeing, or what are the concerns that you would hold for this sort of therapy?
Yeah, there's really three big concerns. So remember, we're overloading the body with a virus, right? And you're given an immune system to fight against infections like viral infections. And so there are some major downsides or major side effects, one of which is thrombotic microangiopathy, right? Which is really just a systemic immune response, can result in renal failure, hepatic failure. The other is gene therapy related hepatitis. So that liver has to clear all of your blood, and it's going to get a lot of that viral burden whether you like it or not. There's no way to deliver anything via IV without the liver getting some of that virus. So we do have to closely monitor for 3 months for any sort of gene therapy related hepatitis. The last, which is a little bit more rare, but often concerning given the disease that we're dealing with, is that a very small fraction there is a risk of myocarditis, where there is inflammation in the heart wall muscle, which particularly for arrhythmogenic cardiomyopathies, which do seem to have an inflammatory component, that's a concern that maybe you could awaken or worsen disease while you're trying to treat it. So those are the three big things that we're watching for. And we have to put the patients in the hospital to do this. So we watch patients in the inpatient setting for 7 days, looking for thrombotic microangiopathy, myocarditis, so that we can be right there to kind of give them, either supportive treatment or actually act to give them, more sophisticated immunomodulatory therapy to prevent any major side effects of these gene therapies.
So are there other types of gene therapies that we should be aware of other than the one that you've just described?
There are. And so there's some. I mean, if you look at the amyloid world, amyloid is a great example, I think, of where the field is headed, right? And so they have what's called antibody oligonucleotide conjugates, which is basically taking an antibody and then an siRNA or a silencing RNA that's meant to knock down an abnormal protein. And so those are already on the market for amyloid. That's coming for other cardiomyopathies. But the holy grail is to get to gene editing, right? That is, at the end of the day, what we're doing. We're dancing around what we'd ultimately like to do is to go into each of those cells and actually edit out the problem that's causing it. That's there for amyloid. So there is a trial that's active right now at Mayo Clinic and other sites that is editing in the liver, so not in the heart itself, but editing the TTR gene out of people to then prevent hereditary transthyretin amyloidosis. And that is an example, I think, over the next couple of decades, where this field is going to turn to is more gene editing technologies, because that is, at the end of the day, the most precision medicine that you can deliver to a patient.
Getting back to the trials that you're involved with here at Mayo or at other institutions that you're aware of, And getting back to the diseases we were talking about, arrhythmogenic, cardiomyopathies, and the various, hypertrophic cardiomyopathy, etc. What are the trials that we should be looking out for in the near future? And if we are interested in anyone has patients that they think may be suitable for these trials, who should they contact?
Yeah, no, those are, again, very, very good questions. So right now, the landscape for hypertrophic cardiomyopathy, Danon disease, is in a pivotal phase 2 that's running at the University of California, San Diego, and the University of Pennsylvania, I believe. Myosin binding protein C3, the major cause of hypertrophic cardiomyopathy, multiple sites across the United States, including Mayo, that is going to an expansion cohort in 2026. That's something where if they want to reach out, if they go to the Mayo Clinic website, if they look up me, if they look up the clinical trials, they can find the contact information for me and the coordinators for that. Arrhythmogenic cardiomyopathy, so a gene called PKP2, there's 3 distinct or separate trials that are running, including one at Mayo Clinic. Those are looking to be very promising. All are wrapping up towards the end of 2025, with several headed towards expansion cohorts in 2026. And then on the docket, dilated cardiomyopathy is going to get its shot in 2026. We know a gene called BAG3, another gene called LMNA or lamin-AC. They're going to have gene therapies that are coming into clinical trial in kind of mid-2026. So it's gone from having 1 or 2 to all of a sudden you can see it's gone to 5, 6, 7. And we know that there's several other lesions where companies are about to file either in late 2025 or early 2026. So it goes from a landscape of 0 to all of a sudden we're dealing with 5, 6, 7, 8, 9, 10 trials. So it's really an exciting time. And what I would tell people to do, the key is you got to get genetic testing on your cardiomyopathy patient, because you won't know that they qualify for this sort of therapy unless you know what the molecular driver of their disease is.
And the majority of these patients, I suspect, are still being managed in highly specialized centers. But sometimes patients are very stable on other medications, and maybe this hasn't been discussed before. But as you pointed out, maybe then you're asking, do you have a genetic variant there? John, as we wrap this up here, anything else you want to add that we may have missed in our conversation today?
No, I just think it's a very exciting time for genetic heart diseases to have disease-modifying therapies in clinical trial. And I think it's an area of cardiology to continue to watch out for, because there's going to be a lot of developments in the future. It's an exciting time to be involved for our patients and to see these therapies make their way through the pipeline into the clinical realm.
Yeah, it's really exciting, isn't it? I mean, as you said, precision medicine, very novel, something that we would only dream about, several decades ago. And who would have thought we'd be talking about zombies here? So maybe we shouldn't bring that up, too often with our patients. Be ready to really alleviate their concerns there. So, John, thanks again for joining us today. And thank you to our audience for once again being with us. And it's goodbye from me, and to our next episode. Thank you.
At Mayo Clinic, learning fuels world-class care. I'm Dr. Peter Noseworthy, Chair of the Division of Cardiac Electrophysiology. I hope you enjoyed today's episode, and I want to let you know about the full courses that we have available. Head over to cveducation.mayo.edu and explore our live and online programs, quick on-demand modules, and CME accredited masterclasses. Join the thousands of clinicians who have already turned their curiosity into expertise at cveducation.mayo.edu.